This is Chapter 27 of Febrile Cerebral Edema, Part 5. We're starting on Reye syndrome. So this is a toxic encephalopathy characterized by fever, profoundly impaired consciousness, and disordered hepatic function. So the definitive diagnosis here is to do a biopsy of the liver, and they find that the liver is enlarged and that it's full of fatty infiltration. They develop very sudden and severe cerebral edema, and that is kind of the biggest concern for death, is that they can herniate and die from that. And then they have decreased enzymes for converting your ammonia to urea, so we will see increased ammonia levels. So diagnostics, as I said, liver biopsy is the best. And then those labs were worried about liver function. So we used to call it SGOT and SGPT, but now they're called AST and ALT, and then LDH, that high ammonia level, because you can't convert that. And with your liver not working, you're going to have low clotting factors, low blood sugar. So the cerebral edema is the biggest concern that you can die from. We're doing supportive care, aggressive supportive care, restoring the blood sugars, using mannitol or corticosteroids to reduce that cerebral edema, eliminating whatever factors we can that increase ICP, and any more if they're treated early and aggressively, the outcome is good. If we let brain damage happen, brain damage is permanent. Our biggest hope is to prevent, and we actually see very little Reye syndrome anymore because we really have stopped using aspirin with children. The aspirin is a problem with viral illnesses. There are still a few diagnoses that we use aspirin with, like heart conditions, congenital heart defects, where we're using it for the antiplatelet effect, or Kawasaki's, which is probably autoimmune, but we avoid it in any viral illnesses. What we really do need to teach parents about, though, are hidden salicylates. Medications like Pepto-Bismol say that they have salicylates in them. They do not say aspirin. Or the other name for aspirin is ASA, right? Acetylsalicylic acid. So parents need to know what names they're looking for and really look at labels of particularly combined medications. Seizure disorders. This is a malfunction of the brain's electrical system. Typically what happens is you get a feedback loop. So the neurons fire and then they trigger themselves, the same area of the brain, to fire again and fire again and fire again. So it's this feedback loop that continues a firing. So we're going to decide what kind of seizures they have based on the site and the cause. This is the most common neurologic dysfunction in children. However, more than half of seizures in children are febrile seizures, and those are not the same as having epilepsy. So this occurs in a wide variety of CNS conditions, metabolic problems that change your electrolytes can cause it. I mean, there can be a neurologic problem with the brain, a trauma to the brain, infection of the brain. Basically, we all have a seizure threshold, and some people that seizure threshold is just lower, and other things that happen to the brain can lower that seizure threshold. So you get this crazy firing and feedback causing it to continue to fire. So we classify seizures as partial, generalized, absence. Those are the most common ones. The partial have a localized onset, a small location. So this may just be the hand twitches or the tongue thrusts. So it's just a small area that's affected. Generalized seizures, we used to call tonic-clonic, and before that we called grand mal. The person generally has an aura before, so they can tell when they're coming because they get some sense. They have the seizure, and then they have a post-ictal state where they're usually very tired. They just need to sleep. They're fine. They're done with the seizure, but they're tired. Their poor brain just had all this crazy firing and it just needs to rest. Absence seizures. I've heard some people call them absence seizures. I think they're trying to sound French, but anyway, absence or absence. We used to call these petit mal. These are where the person just zones out. Usually it's only 5 to 10 seconds. Sometimes they have 20 or more a day. They usually are short. They're often hard to figure out because they just sort of stare off. But when the person comes back, often they're a little disoriented, take a little time to figure out, what's going on again. Atonic or akinetic, these are sometimes called drop attacks. This is where the person loses muscle tone, so they will just fall to the floor. A myoclonic seizure is a sudden muscle contraction. And those can be painful, like our kids who have CP, if they have myoclonic seizures, it's sort of like getting a cramp in your muscle is what it seems like. And then infantile spasms. This is seizures that happen in an infant less than 6 to 8 months old. This has a poor outlook for normal intelligence. The vast majority of our seizures in kids are febrile seizures. In fact, they say 3 to 8% of children will have them. Most common is between 6 months and 3 years, rare after 5 years old. If a child's had one, they are at higher risk for having another, but again, by 5, they usually won't have any more. A tepid bath is not recommended for fevers or febrile seizures, partly because it's pretty ineffective in bringing temperatures down. And if you get a child cold, they're going to shiver. That shivering produces a whole lot of energy, right? That's increased metabolism. The side effect of metabolism is temperature. So shivering makes your temperature go up. So we don't want to put them in cold water and make them shiver. And really, Tylenol is the better choice, unless you have a neurologically induced fever where they have increased intracranial pressure that's causing the fever, where it's true hyperthermia. Then we can try cool packs or a cool blanket on them. But standard fever, people kind of got carried away with this, and we're saying just don't do it. It's not really very helpful. So the cause of febrile seizures, we don't know for sure. The height of the seizure, the height of the temperature seems to be the problem. We used to say it happened when it was going up really rapidly. It's not the speed that it goes up, it's the height that it goes up to. But the seizures happen while the temperature is climbing. But again, we don't entirely know why. The treatment, antipyretic, because they're running a fever. Give them some Tylenol. Rarely do you need seizure meds for these kids. We do want to treat fevers a little at a lower rate on these kids in the future because they are at risk for having them again. But once they're over 5, they're not likely to have another seizure. Most of them, 95%, do not develop epilepsy or have any sort of neurologic damage. We do tell parents to call, if a seizure lasts more than 5 minutes, to call the ambulance. Most do not. So the therapeutic management during any kind of seizure, our goal is to control the seizure, reduce the frequency or the severity of the seizures, figure out the cause and correct it if we can, help the child with seizures to live as normally as possible, and to promote normal growth and development. So you may hear the term status epilepticus. This is a seizure that doesn't stop. So it either goes on for 30 minutes or it's a series of seizures, but the patient doesn't ever really come back to their pre-seizure level of consciousness. So what are we going to do in status epilepticus? Well, like usual, maintain an airway first, and monitor them for apnea. Make sure they're safe. We need to get an IV in this person because we don't really have any other route for giving medications, right? And our meds are going to be IV diazepam or lorazepam, and then we may do phosphatoin or phenobarbital, and support the family. Really scary when a child's having a seizure and it's not stopping. So most of the time with seizures, we try and maintain a child on just a single medication. So monotherapy is preferred. And then we gradually increase the dose so that they don't get too many side effects, so they get used to it, and we figure out what dose is effective for them. Most of these drugs have a pretty narrow therapeutic window, so we've got to do drug levels. And then we're monitoring for side effects. Most of these, they stop the central nervous system from overreacting, which means they slow it down. So they're going to make you sleepy, ataxic. Most of them, allergy is a concern. So we're looking for rash. And if we don't catch an allergy in the first exposures to this medication, these can be really terrible or life-threatening allergies. Sometimes we need to do more than one medication, polypharmacologic treatment. As the child grows, they're going to need more medication. These are medicines that you can't start at a high level. You got to start low and slowly let the child get used to as you work it up. You got to do the same thing, taking them off. You can't just suddenly stop. Some parents try ketogenic diet. This is a high-fat, low-carb diet, very strict and very hard to follow, but for some kids it really helps. If nothing else works, there's a surgery where they put in a vagal nerve stimulator. So every time the child starts to seize, it goes off and stimulates them and stops the seizures. And sometimes there is no other choice but to do surgery. They will actually go in and figure out what part of the brain is triggering the seizures, and then cauterize some neurons in that area if they can figure out which ones are causing the seizures. Home management of seizures. Let's make sure family is trained in CPR. Most seizures are short and resolve on their own, but if they don't, we need people trained in CPR. At home, they're not going to give IV medicine, so they should have rectal diazepam in case we have a seizure that doesn't stop. Activity restrictions on a individual basis. If we need a child to wear a helmet or something, or make sure they don't swim alone, that there's always somebody there, and that teachers and caregivers understand this child has a seizure disorder and what needs to be done. So during a seizure, someone needs to time when it started and how long it goes, so when it ends. We want to monitor, assess the behavior and the movement. So what are they doing during the seizure? Do they have any color change? Are they turning pale or cyanotic? What are their eyes doing? Eye deviation is common, so look for the eyes. Respiratory effort, are they breathing adequately? Are they incontinent during a seizure? That's very common. Do they have a post-ictal state? And that's where they are now done with the seizure, they're just tired. In order to really monitor all those things, someone has got to stay with the patient during the entire seizure. And I guess I should say our big goal is to keep somebody safe. So if they're not in a safe setting, we're going to make sure we get them to a safe setting. So if they're up high, they're sitting or something, we're going to move them to the floor. We're going to get anything that's around them out of the way so that they don't hit it or hurt themselves. Never put something in their mouth during a seizure. You're not really going to be able to ventilate them because everything clamps down so tight, so you may need to just blow some oxygen past them if they're turning pale during a seizure.